Thank you very much, Dylan. Thank you very much for asking me to speak again. I know I've been here many times, and it's always a pleasure to talk to the audience. I do want to mention a couple of things about Galit's excellent presentation that you heard before. The first one is related to what's happening to all of us after having lunch, which is called postprandial sleepiness. And, and believe it or not, it actually is an important, I mean, jokes apart, symptom in patients with Parkinson's disease. And the reason that this happens is not related to the same thing that happens to all of us after eating a big meal, which is without Parkinson's, and that is related to the metabolism of the food that we consume. What happens in patients with Parkinson's disease is, as she mentioned, the dysautonomia, or the automatic system that controls our blood pressure, is supposed to allow blood circulation to redistribute depending on need. So if you're doing a workout, the muscular or muscle vascular or blood flow is different than when you're not. Well, when you eat, guess what happens? There's what we call splanchnic or gut redistribution. Naturally, you want to absorb your food, so blood flow goes to the gut, except that it's only supposed to be 15 to 20% for a small amount of time. If it's 45%, then it takes away from cerebral perfusion. So the problem with postprandial sleepiness with this is postprandial hypotension. She talked about orthostatic hypotension in that case. And this is extremely common and disturbing because patients will lose their blood pressure after they've eaten a big meal. One of the other very important dietary suggestions we make in patients who have this is to eat very small, multiple meals. So you have kind of two birds with one stone kind of thing. I tend to not use that example, being a vegetarian, to kill two birds with one stone, but still, or you can say two tofu patties, I suppose, with one stone. That doesn't go across just as well. But I mean, the idea is that what ends up happening is you not only have your protein interaction taken care of, which is critical, right? Critical, and you also have this postprandial syndrome taken care of. The second point I wanted to make, which is even more important, well, actually equally important, is that she talked about non-motor symptoms, which is excellent, but non-motor symptoms do not present as independent fluctuations, ever. In the last 30 years of movement disorders, I can tell you, non-motor fluctuations always happen with motor fluctuations. So it's great to be able to ask about anxiety and mood and all those other things, but I have never seen, in the last 25,000 patients that we've looked after, somebody that has no motor fluctuation at all and only has a non-motor fluctuation. It is possible, however, when people present with Parkinson's disease as their initial diagnosis, to have the non-motor symptoms as the initial presentation and not have motor symptoms. So mood, anxiety, depression, etc., can be the earliest presentation of Parkinson's disease. But the reason we don't, I mean, it's great that we've concentrated on the non-motor symptoms. I did my fellowship with Tony 10 years before Galit. And so we knew that non-motor symptoms were there. But the reason that we don't use them even as of today for diagnosis is because many people can be depressed without ever getting Parkinson's disease, you see. But people won't have asymmetric rigidity, bradykinesia, stiffness, and shuffling of gait just because. That doesn't happen. It's pathological. Whereas mood dysfunction, anxiety, all of the other things. So the subtlety or the lack of ability to diagnose Parkinson's disease based on those symptoms is very hard. And the same thing is true when it comes to what she was saying as dopamine unresponsive symptoms in terms of actually just being anxious and has nothing to do with wearing off. That doesn't mean it's not a Parkinson's. So it's not as simple as having somebody just simply having non-motor. If they go hand in hand, it's great. You know, you become stiff, slow, speech drops, and then you become anxious, you sweat a lot. All that's part of the non-motor and motor wearing off. But when it happens by itself, it is very difficult to know and dissociate that from just typical anxiety, et cetera, from Parkinson's disease. And so pharmacotherapy for this is exceedingly difficult. And one of the reasons why I think when my senior colleague and mentor, Dr. Brian Young, is here, and you know, we will discuss why it is so difficult to manage Parkinson's disease, because this is a non-static disease. It doesn't remain the same, right? So there's no controlled Parkinson's disease, which brings us to this construct of advanced, I specifically have put therapy doesn't mean advanced Parkinson disease, okay? Two very different things. And this has been a big mess in the literature in the last, 15 years, because of the fact that people confuse advanced Parkinson's disease with what we have called advanced, or now the word is device-aided therapy. You can use device-aided therapy in person that is not advanced. Advanced Parkinson disease, most of the time, patients will not qualify for device-aided therapy because advanced means uncontrolled falls, dementia, swallowing difficulties causing pneumonias. These are patients that are advanced. We are at the end of the road of therapeutics, right? So don't confuse the word advanced as being a patient that, in our clinical definition, is an advanced patient, right? So we have lots of therapies that we use, but those patients are not advanced because those are patients that are having what? Having fluctuations. So the definition of use of device-aided therapies, which we'll briefly talk about, and she mentioned one of them, is in those patients. Can I actually have the clicker? Yeah, thanks. Perfect. In those patients who are still responsive to medication and really well. We don't use these therapies in patients who are not responsive to medications. We don't. You wouldn't put a duodopa pump, which we'll talk about briefly, in somebody like this lady that was responding to liquid levodopa. By the way, liquid levodopa we were using in the 80s and early 90s was a mess. I mean, it's hard to maintain. It's great, and that's what happens because you have to take this aliquot of liquid stuff, which dissolves half the time and doesn't dissolve by mouth. It tastes really bad, and you're going to drink all the time, which means you pee all the time. I mean, it sounds good on paper, but it never worked. And so that's why the advancement of this into a duodopa gel has been fantastic, because I've used liquid levodopa and there's butter all over this thing. What did I do? Good God. I mean, I know I like my hands soft and cuddly, but that's a bit much. All right. Excuse for that. These are a different technical problem than Galit had. All right. Okay. So what are we going to talk about? I'm going to get a dystonia on my neck like this. Okay, well, what we're going to talk about, as I briefly mentioned, I wanted to really talk about this advanced. So in the second definition, I think Dr. Young and I talked about, is that advanced also means the ability of your neurologist to be able to treat you, right? And so if the neurologist is unable to treat beyond a certain point, then to that individual, the patient may be advanced. And as Galit's case, they were able to rearrange the medication for the first little while and get good results. That doesn't mean that the person is actually advanced. So there's a lot of nuances. And so I really want to separate the patient population that we still are aggressively managing, not calling them advanced. Whereas those that we call advanced are the ones we don't have treatment options, even in our movement disorder center, right? So those are the patients that are truly advanced. And we're going to talk a little bit about 2 or 3 things: duodopa pump, apomorphine, which is available now as an injectable. It's been in Europe 30 years. We just got it in Canada a few years ago. And the new sublingual film, very briefly. And then everybody knows about DBS. If we get a chance to get to that point, we will also briefly mention about deep brain stimulation, which is our mainstay treatment. And I'll tell you that, I'm from the era where levodopa already was there, but DBS was just starting as I was doing my fellowship, and it revolutionized our treatment for those people. It was as much a box of chocolates from the patient as levodopa used to be. That's what our usual mantra was. If you want a box of chocolates, or a bottle of wine or whatever you like, it's levodopa. And DBS has done that for a small group of patients. Duodopa, very similarly, dramatic improvement, as you saw, in selected patients. Right, and so, just summarizing what I was saying, is there any way to have a microphone? I really can't see those slides very clearly, but I guess not. Oh yeah, this is on? Okay, good. Okay, so I don't need to stand here. That's perfect. Thank you. All right. I wasn't sure this was on because I was standing next to that one, so interference. So, oops, sorry. Duration of disease, severity of symptoms, which symptoms, responsivity of medications, and then really the definition of advanced Parkinson disease that we're going to talk about today is that one line: occurrence of fluctuations and dyskinesias, still responsive to medication, still able to produce improvement in quality of life to what the patients would like. That's the key requirement of what we would term as being device-responsive patients with Parkinson's disease, right? So all of these terms are used, but you could get to that point in 5 years of disease, or never get to that point for 15 years, right? So temporal association is wrong. Severity of symptoms, well, somebody can have really bad tremor, but they could be functioning completely well. Is that patient advanced if you're not able to control the tremor? Well, not advanced. It simply requires a different kind of treatment. We might do a thalamic DBS in that patient, get rid of their tremor, or inject Botox in their arm and get rid of their tremor. So this is not advanced Parkinson's disease because somebody's not able to treat them. So again, all of these symptoms, responsivity are important in how we manage. The one criteria that we do use, which is DBS, is age, and that's related to how we target the brain, and I'll talk about that briefly at the end. Right, so let's talk about these in detail a little bit. So continuous dopaminergic stimulation, we know, continuous delivery of dopamine, this chemical that is being reduced in the brain, decreases motor fluctuation in advancing PD that is still responsive to drug, right? So advancing PD. So we've got 3 device-aided treatments. That's the word that we're using, and I like that word. What is called levodopa carbidopa intestinal gel. This is a pump that you saw Galit show you, and I'll show you a couple of pictures of that as well. Apomorphine, which is not a narcotic, by the way, it's not an opioid. It sounds like that, but it's an analog of morphine. It has no opioid properties. It is the best dopamine agonist on the planet. It's even better than levodopa, right? And it works instantaneously. The problem is, has a lot of side effects. We'll briefly talk about it, but it's super, super good. And in Europe, there's an actual apomorphine pump that you can get, which is, I don't think at the moment is coming to Canada. And then, of course, DBS. We are going to get another new treatment that, in fact, one of our partner companies that has championed LCIG, AbbVie, is potentially next year bringing to the market another kind of pump, a levodopa pump, which we won't talk about today. And then, of course, very simply, who are the candidates for these treatments? As I mentioned before, significant disabling off, but still have a good on, right? So these are not unresponsive patients. Your patients that are still very much responsive to medications, dyskinesia, and no mild to or really no cognitive impairment. In fact, the advanced patients are the ones who are not like that, who are not responsive to medication, falling a lot, are having cognitive impairment, hallucinations, wheelchair dependent, all of those kinds of things. Those are patients we will not consider device-aided therapies for obvious reasons because they're not responding to medicine. So this is the levodopa carbidopa intestinal gel that Dr. Galit has already introduced to you. This is actually a gel pack, a cassette like my pager, and brought it specifically for that reason. Clicks in like that, and there's a pump above that and tube in the jejunum, which is where levodopa is actually absorbed. So she was very right in saying that if you have reduction in motility anywhere in the GI tract, then that pill that you swallow is going to just sit there. It's going to sit there and not go anywhere, and it doesn't do anything until it actually gets to that small bowel past the duodenum, which is the first part of our small intestine, into the jejunum. That's where it's absorbed, and it's absorbed as a protein, because levodopa is actually a protein, dihydroxyphenylalanine. It is a large amino acid, neutral large amino acid. So any proteins that you eat, your pot pie that you had protein in it. So if you're going to eat your levodopa and pot pie together, chance of that interfering across the intestine is very high. And guess what? The same protein transport truck that carries the levodopa from the intestine in your blood is also in your brain. Same one, right? So there's interference, and the truck doesn't know what to put in it. It just takes protein and puts in it. It might be 5 milligrams of levodopa or 50. And so you have fluctuations. So she's saying, and she's absolutely right, that is our mantra. First thing we tell people, 1 hour before food, 2 hours after. That much time, lots of liquid. Swallow it through. It has to get down here. Otherwise, it's stuck in your esophagus. You say, well, it's been 1 hour, but it's actually still here, right? And so that's the kind of thing that you see in the fluctuations in the oral, the red, right? So the red, here, you'll see that kind of fluctuation of serum level. If that's happening in the serum, happening somewhere in the brain. With LCIG, this intestinal, just simply peripherally, we're not doing anything in the brain with this drug, right? It's going into your jejunum. It's still levodopa. It's going to the same spot, except it's delivered directly to that spot. And hence, look, you've got serum stability of that drug going in versus this is what's happening with oral. The other beauty, of course, is that you don't have to take anything by mouth. You can eat protein anytime because it's pumped continuously. And so the advantage of that is that you don't have to have. Still, I distribute the meals in all my patients at this stage, right? And so a constant plasma level can be achieved. And that's that same pump that She very nicely showed it, some weird, carboxymethyl cellulose aqueous gel. It's 20 milligrams of levodopa and 5 milligrams of levodopa per mil, and it's pumped according to that plan that you're showing. You give a bolus in the morning and then constant throughout. And yes, we do use over 24 hours as well, but at the end of the day, when you go to bed, you unplug that tube because it might get caught in bed sheets and that kind of a thing. And then if you want to turn, get up, you want to pay attention to that, right? So directly into that proximal jejunum, via percutaneous endoscopic gastrojejunostomy, so that's what that stands for. And percutaneous meaning through the skin, endoscopic meaning through the scope, so it sounds extremely intelligent, but it's just words. And so gastrostomy is a whole gastrostomy. You make a stoma, a hole into the stomach, and the gastroenterologist does that through the tube, puts the other tube in. The picture shows you that, like that, into the stomach, and then it hangs with a pigtail in the small portion of the small bowel, the proximal jejunum. The cassette is included like this, and you start the pump, and away you go. And then you walk around with it. You have to be careful. It is a pump, and it is, heavy. It's big, and you have to make sure you take care of it. You can't jump in a pool with it, obviously, and these kinds of things. It's an electronic device, and can't get it wet and shower over it. You have to be careful with these things, but it is extremely useful, and we've used it extensively in many patients. So again, the indications I've already talked about, most suitable candidates, and I want to reiterate this because it has created this myth in the medical literature as well, and telling patients, well, you're advanced, hence we're giving you this therapy. That is not correct, right? And so they're levodopa responsive patients, such that they are now experiencing motor fluctuations and dyskinesia. Look, despite optimal oral treatments. And 1 to 2 hours is too short. Most of these are patients that are there experiencing many hours of intermittent, unpredictable off time. And that's what it is. If you know that lunch is going to be at 1 o'clock and I feel hungry at 12:30, it's great. But these patients don't. They start feeling hungry at 9 o'clock today. Tomorrow, they don't feel hungry till 3. And it's all over the map. And these fluctuations are related to that erratic absorption in some patients, right? And so ideas that they're still responding, you are still responding, but having these unpredictable responses, those are the patients that we usually consider. And that happens usually between 5 to 7 or 8 years. The reason we say less than 10 years is a sort of soft thing is that above that, 10, 15 years, patients with Parkinson's will actually become advanced, which means that the symptoms that they then get at that time are not responsive to medication. They switch over from this levodopa responsive to not responsive. And then that becomes very difficult because then the device-aided therapies cannot help that either, right? And then because some of these are devices, including the apomorphine pen I'll talk about, you need somebody good around you to help you with that, right? So generally, predictors, younger age, obviously. I mean, you don't have other illnesses at the same time. No psychiatric behavioral symptoms, and that is important because people that have uncontrolled hallucinations, for example, with that lady that we were seeing, if it becomes such that you cannot control them medically, then you don't want somebody that has, a tube sitting there and you're going to pull that tube out, and that has happened to us, or they're not able to look after, or not aware that the pump is connected to the tube. You take your pump and put it over here, and then you walk away, and then yanks on the tube. This kind of thing. So you need somebody that's able to take care of a machine. It's a device, right? And generally because of that shorter duration of disease, right? And most of the times, if somebody's on 500, 600 milligrams of levodopa, we're not going to put a pump in them because you can increase their levodopa. Usually, because the cassette has 2,000 milligrams of levodopa, we are looking at somebody that's between 1,600 up to 2. That's the kind of levodopa dose that they're getting, like the lady that she showed. Every 2 hours, 1.5, whatever, 135 milligrams of levodopa that person was getting. So this is the kind of person that we would consider not demented, not able to take care of themselves, etc. So that's the requirement, right? And so obviously it is a device, and we've had experience with the device now for quite a few years. There's a lot more experience in Europe for 15, 20 years. People have had experience with this. Because it's a device, the discontinuation rate is not related to the medicine, because most of our, all of our Parkinson patients that are getting this device are already on levodopa, so they know this. It's related to the device. Some of these are, lack of care of the device, but most of them are related to the fact that, there's infection around the site, so stomal infection. Rarely you can have things like a peritonitis infection in the intestinal region, abdominal pain, or insertion problems, bleeding, perforation, those kind of things. And of course, disease-related is not side effect of the device. It's just because the disease progresses and we don't have any ability, even with these devices, to slow down the progression of the disease, right? And so naturally, you got to maintain the device. And this is a problem practically for us because, we're neurologists, we're not gastroenterologists. I don't know how to manage somebody's stoma or their infection or those kind of things. And so literally, we need to have a partner that is a gastroenterologist who's to put this thing in and then manage the device-related complications. And that has been a challenge across, well, in Canada in general. We've had that challenge in London. We're a huge center, but we've had trouble trying to get the gastroenterologists interested. And I can understand this because it's a procedure. They're not actually looking after the person. Whereas when they do an endoscopy for an ulcer, the person is also looking after a GI problem. And so they are also primary care treaters of that condition. Here, I send the person to them, they do the scope, they put the tube, and then they come back to us for management because they're not managing the Parkinson. So it feels like a technician's job to some extent. But we've had good partners. They're very busy doing their other procedures, so sometimes there's a little bit of a lag with this. With DBS, it's a bit different. Even though the neurosurgeon is putting in the device, once it's in and it's healed, it's inside. So neurosurgery has to do nothing, because you can't pull at it, you can't do anything as long as it's buried inside. So yes, it is also with a partner, neurosurgery in that case, as we'll talk about briefly, but it doesn't have the same level of involvement from neurosurgery as GI that we have for LCIG, because we constantly need the gastroenterologist to be involved with us, right? And so there are programs that are available for device-aided therapy, and AbbVie, our partner company, has done a super, super good job having AbbVie Care, which is actually a expert nursing and support system program that we critically depend on in the community, as you'll hear from Dr. Young and others in the panel, that we really do need such kind of a collaborative outside our clinic involvement, and they've really done a super job. Without that, we would not be able to, as centers, at least in my center, manage to take care of these complex devices, this device particularly, right? And so again, the same idea in terms of how to choose. Generally, above the age of 70, we don't do deep brain stimulation because of the fact of anatomical localization. What does that mean? Well, we've got to put an electrode about this long, 6 inches deep, into a structure that's smaller than my little finger's nail, right? And so half of that, it's 5 millimeters by 7 by 8 millimeter, deep down, about that deep into somebody's brain. Well, we have to target that region. We put a stereotactic frame and target it, which I'll talk about at the end if we get a chance. And we need to be accurate, and we use an atlas. We basically use a GPS guidance system, essentially, right? But if the map in the brain has changed, all of a sudden 2 new buildings have been put up, and it's not on the GPS, where you're going to end up in somebody else's house, right? And which depends on where you want to go. It may not be such a good thing. And the problem with that is that if you miss the structure, the brain is not something that has lots of space around it, say redundancy, right? Maybe some of them do, and then they do. Then they're in politics, but so, oops, sorry. Bad. Inner voice. Oh, cognitive impairment setting in. But anyway, the problem is if you miss that target by 2 millimeters, you're in the internal capsule on one side, or in the eye field, your eyes are skewed. So it's not easy management, right? And so you have to be accurate. And if the brain, beyond a certain age, shrinks such that instead of 2 buildings, there are 10 buildings, my GPS is going to be off. Right? And that's the reason why we don't do DBS in patients beyond a certain age, because your targeting is bad. And that's what in Toronto they do. We didn't initiate it in London. MRI-guided focused ultrasound, and you actually make a lesion in the brain. And there's a PD. But you can imagine if my electrode placement, which I can just turn off the device if it doesn't work, if you make a hole inside the brain and burn a hole in the brain, you're off by a few millimeters. Well, you're kind of done, isn't it? So that's the reason why ultrasound-guided lesion therapy for Parkinson's, older you get, same problem. You've kind of parked your car, and you can't do anything. So that's LCIG very briefly. And then we move on to this new thing, which is apomorphine, new for it's not new anymore for us, but new in the sense that the number of people that we've done as compared to DBS, which we've had over 250 done in London now, is less because it's a new product to us. But it's been used extensively in Europe, and it is an excellent, excellent medication. I really find it very useful. It's not that we don't want to use it extensively in our center, but as many of you might guess, the tertiary center of excellence kind of patients that we see are far more advanced than some of the patients that might do better with the apomorphine or sublingual film, as you'll see. And just because our patients are much more complicated, we are using this apomorphine pen in a very innovative and novel way. May not be something that is typically used in patients with Parkinson's. We're not going to talk about that. So what is apomorphine? As I said, it's not an opioid. Sounds like morphine, but it isn't, right? So that's the way it is. It's apomorphine, that's not morphine. So why was it called apomorphine? Well, organic chemistry, the molecular similarity is to morphine, hence that way. But it's a potent dopamine agonist, which means that it behaves like dopamine, not dopamine, but it binds to the same receptors, what we call D1, D2 receptors, many subfamilies of these receptors to which dopamine binds, kind of like a key into a lock. And this binds it tremendously well and binds it very quickly. It's a subcutaneous injection. As I said, it's approved in Europe in 1993 and 2004 in US. We got it, I can't remember exactly, but 3-4 years ago into Canada. Doesn't matter, recently anyway, compared to their experience, right? And so it has a specific requirement. So when Galit showed the symptoms of that patient in that slide, that person had what we call early morning akinesia. Let's just use that as an example. So you get up in the morning at 6 o'clock, haven't yet taken your medication, you just can't get out of bed. You're stuck, cannot. So your care partner has to basically lift you out of the bed, give you your medication, then you sit and wait for 45 minutes till it comes on, right? Our traditional treatment for that has been, well, just get up and swallow your pills and lay in bed staring at the ceiling for a while. Okay, I mean, I tried that. It's exceedingly boring, let me tell you. It's not, especially for me. And so it's not a good strategy to do because, I mean, you're just going to lie in bed stiff for that length of time. And it's that kind of, and that's one example, that kind of severe akinesia in the morning that would be beautifully treated with an apomorphine injection. Literally works in 5 minutes. So the care partner gives the injection, and you're up in 5 minutes. And I've seen this in my clinic. We've done many now over the last little while. And the person comes in a wheelchair with the caregiver, give the injection, they're up and they go to the bathroom. It's that good, right? But everything that's that good comes with something that's not that good, which are the side effects of it, which we'll talk about very briefly, right? It's fast, reliable, reversal of off. Can happen in the mall. You're in the grocery store and stuck, sudden off. She described those things, right? Sudden off, dose failure, that little list that Galit showed, same kind of a thing. Well, if you've taken your levodopa and the dose has failed, it's 1 o'clock, you're at somebody's place, or 5 in the afternoon, injection, up and away you go, right? It lasts about 90 minutes, right? So subcutaneous injection along with the oral drugs. We would not use it as monotherapy because it just doesn't have that kind of practical use, right? And so usually adults not sufficiently controlled and having this kind of a off symptom that is quite sudden. You wouldn't want to use it in people that have mild wearing off, right? Mild fluctuations we don't use. We've got other strategies to use for that. Right, so there's the pen. It looks like an EpiPen kind of thing. Contains 30 milligrams, total of 3 mils of apomorphine. Use it for about 2-3 days, and needles for injection need to be changed. So that is a little bit tricky because you can see that it has this little cap that you have to put on and twist and take off the cap. So the person that's off, and if they're severely off, may not actually be able to do it. And if you've got a bad tremor during your off, you can just imagine trying to get that thing to click and it doesn't work. So you need to have, like all device-aided therapies, some caregiver to be able to do that, right? And so, most of our patients, thankfully, do have that, and if you don't, then there's a different strategy we may have to use, right? And then I wouldn't really wait for the solution to turn green to throw it away. Generally not a good idea to have rotten apomorphine injected, and so, make sure that and we teach this anyway, right? So we teach, there's an algorithm for initiating apomorphine. We bring the person into our clinic because of the side effects, which I'll talk about briefly in a minute, right? And so intermittent subcutaneous injection, adjunct, and we will talk about the initiation with an antiemetic for one of the side effects, which is intense nausea. I've been using apomorphine since the early 90s, 1993, 94. We used to get it from Health Canada in Toronto, and we would use it in the OR for doing some specific physiological testing. And we would pre-medicate these patients with domperidone extensively, domperidone an anti-nauseant. Otherwise, you'd have terrible nausea and vomiting in front of you, which is not good in the OR, right? And so, even with the current clinical we do. So it's determined on an individual dose basis, which means we have to titrate, and we do it, right? In a clinical setting to monitor the second and really important side effect, which is that orthostatic hypotension. So secretly, I wanted to talk about that orthostatic hypotension as a segue into the side effect, which doesn't happen with LCIG, but will happen with apomorphine, which is substantial drop in blood pressure. So you've got to be really careful in terms of how you monitor these patients, and that's why we would bring you into our clinic, our nurses, our fellows sitting there, and we take your resting blood pressure. We give a test dose of starting of 2 milligrams, see what happens. It's a bit of a tedious process because you've got to wait for it to turn on, and then you can't give the next dose till the half-life of the drug is over, which is about 90 minutes. You wait for that half-life to be over before you give second, otherwise you'll get a cumulative effect. So you can't say, oh, it didn't work in 2 milligrams in 10 minutes, here's another 4 milligrams. And blood pressure goes to 30/10. That's not good, right? And so we have to wait and then wait. So sometimes, not commonly, you'd have to wait for 5, 6 hours in the clinic. So it's a long process. Once we have titrated you to the dose that's appropriate for you, that's your dose, right? And then you go home with that dose and only take it, again, per movement disorder. It's only in the movement disorder clinic that I would initiate it. I don't have time outside, I would think, to be able to do that. And that's the titration phase, right? And we give that dose to be taken X number of times a day. Now, if you're wearing off 7 times a day, that's not a strategy. Then you go to LCIG kind of strategy. This is for what we would call rescue therapy to some extent, right? So it's not a continuous regular therapy. So that's it's done. It's like this. It's attach the pen needle, select the dose. It clicks up, and you pull it to load the dose, stick it in, and push it in. It does require some force to push it in. It's not, thankfully, because you don't want to just plop in. And so you can prepare the pen and keep it, though. You can prepare it, have it ready if you know that that's going to happen, so you don't actually have, and because you can pull it up and leave it up, it doesn't push down on its own. You can take it with you somewhere and then get it out of your purse or bag or whatever and give it to yourself. It's possible to do. We have not had that requirement, thankfully, in our patients. Caregivers have always done it, right? So you do not need to prime the pen. So you don't need to actually get it to the tip of the needle. The first dose works like that. And you can give it in any number of places, leg, thigh, shoulder. If you rotate it around, local site reactions, which can occur, are minimal in our cases. And then the adverse events I've talked about. So local bruising, swelling, itchiness can occur, but it's the nausea, vomiting that is there. So we give antiemetics like domperidone for a couple of days, 3 times a day, and pre-medicate so that you don't come into clinic while we're titrating and have severe nausea, because then we have to stop, right? And so that's done. However, after maintenance therapy, what we have found is we're able to get people off of the anti-nauseant and continue on the apomorphine just like it. Right? Just without, that depends on the individual as well. So that's the apomorphine injection therapy that's available. And we talked about this, the postural hypotension. You could get dyskinesia. It is a potent dopamine agonist, so you might have this. I've not seen it in any real clinically significant way. You can have it, but we're monitoring. And so we monitor this in front of us during that titration phase as to what happens, right? And so, but again, it's a dopaminergic drug. It can have the same complications such as hallucinations and psychosis and other things that can occur with any dopamine agonist. So that's the apomorphine injection. Moving on to the sublingual, new. This is actually new in the world in the last couple of years. It's a sublingual form of apomorphine made by Synovian, the apomorphine injectable, Movapro Paladin. We talked about AbbVie and the LCIG pump. 10, 15, 20, 25 milligrams. This is something that actually is easier to initiate in the community because it doesn't require this kind of monitoring at least on label. We've always done the few that we've done in clinic just to make sure, but it is something that probably more gentler off patients, not the ones that are so stuck that we need immediate. So you could use this in a scenario, for example, that you're going for an event like this and you want to make sure you're not going to wear off terribly and you are feeling that, you can take this under the tongue. It's a sublingual film. It's available. I'll show you the pictures of it. It's very tiny. It doesn't work as fast, though. It doesn't work in 5 minutes. It takes 20 minutes or so, kind of like your levodopa. All right, so sublingual film, blue to green, regular rectangular film unprinted. So this is 10, 15, 20, 25, 30, but you can see it's pretty small in size, right? And it should, the dose, like we talked about apomorphine, is separated by at least 2 to 3 hours, 5 films per day. And I've actually had the company people tell me that in the community it has been initiated more often than actually in the movement disorder centers, because we see the more difficult to manage patients. And this is something that we don't have as much use for. The injectable I've used far more in our clinic. And you can get a mixed bag pack, right? So a sorted pack, so to say, and that's how it's done. But the interesting thing about this is that you have to have it under your tongue for 3 minutes. It doesn't dissolve otherwise, right? And so you have to, then that's something that you have to be patient with, letting it dissolve. Swallow it, it doesn't work anymore. And it does cause blistering in the mouth in some patients as well. So there are some oral ulcerations and things that can happen. But the data is pretty clear. I mean, it's apomorphine. If it gets absorbed, you'll see that the end, this is the, you need to have some random graph with data points. Otherwise, it doesn't sound scientific, right? So we put the graph up there. And there you are. So you can see that the UPDRS, the Unified Parkinson's Disease Motor Score, stiffness, shuffling, et cetera, that we measure every time in clinic, bad, good, right? So it reduces dramatically in patients that are taking this sublingual, which is expected. It's apomorphine and it works, right? And so, and that's, we don't need to talk about that. And this is secondary endpoint, since we have talked about non-motor symptoms in the past lecture. This is the other effects of apomorphine sublingual in benefiting anxiety, mood. If it's wearing off, it also helps the other secondary endpoints of this. But unlike the apomorphine injectable, you can see that this is levodopa time to onset. So I've taken my oral levodopa. It peaks at about 30 to 45 minutes, maybe even up to 60 minutes. Levodopa is peaking. Apomorphine sublingual doesn't work in 5 minutes. Begins at 15 and really is peaking at 30 and then tapers off after that. So if you have somebody that is stuck in a mall or in the morning, severe stiff akinesia, it's not going to work as well. It'll work better than levodopa orally at that time, but it is not as good as the injectable at that time. So those minor wearing offs, not minor, but substantial enough to want medication treatment that happen intermittently through the day in patients that are still not severely disabled, Kinmobi has a good place in managing that. And again, the same kind of side effects that you'd expect, in some nausea, somnolence, fatigue. And this thing, this oral mucosal erythema, is important. And you get the redness in the mouth and sometimes ulcerations in the mouth as well. Those are really the main important things that, and funnily enough, this is very interesting actually, and I'm just going to throw it out there because it's a point of discussion amongst us. Huge amount of yawning in patients. No idea why that is. I mean, in terms of whether dopamine is responsible acutely for producing yawning, I have many other reasons why I yawn, but certainly it isn't dopamine. But it is a known side effect. And patients I have seen initiate this, and they're saying continuous yawning like that in front of you. So going, I know I'm kind of boring, but that's a bit much. I mean, come on, have some social respect. But no, it's the sublingual film that does that. And interesting, it's at the bottom, but quite common actually. 12% of patients have yawning, an odd thing. Finally, if I have 5 more minutes, 10 minutes, something like this, we're going to talk about DBS, because it's a blitzkrieg kind of thing, rapid through these device-aided therapies. Each one of them, to do justice, is a talk in itself or more. But just wanted to introduce these topics and the sort of key points as to what we do and look for in patients and how we manage in clinic. So DBS, of course, is well established. The first patient that was done in Toronto, actually when I was a fellow in 1993 with Andres Lozano, who had just returned, was a patient with dystonia that was done, not a Parkinson patient, but it had been started before that in Atlanta and in France, deep brain stimulation. The technology of deep brain stimulation and the idea of deep brain stimulation is about 100 years old, so it's not new, right? So it was being done in the mid-1900s. But the problem was the technology that was required to chronically implant the DBS devices was just not there. You can imagine, the first computing system that we bought when I was at MIT was this big building with the Sun microstations, which had a floppy disk memory now of, what was it, 4 megabytes. 4 megabytes, right? And I'm not that old. I mean, and this is MIT. This is the premier technical institute in the world. And I'm writing code on this huge, big Sun microstation. Now, I mean, this thing can do 10,000 times what my big machines could do. So same thing, the science behind deep brain stimulation was there those days. We knew that we could modulate the electrophysiology, the electrical impulses and patterns of these structures in the brain, but we just didn't have the technical know-how to be able to make the electrodes small enough. And literally, I mean, since '94, even when I started in London in 1998, that tech has evolved more and more and more. But the basic principle has remained the same. It hasn't changed, and which is that we want to be able to take a patient that is this, by the way, these dashed lines we call in our lingo therapeutic window, right? So below the therapeutic window is the off. Above the therapeutic window is mobile with dyskinesia, and in the middle we use motor, right? So mobile, but you could use the non-motor package there as well. So improvement in symptoms that are improved by drugs. What happens in patients with Parkinson's disease is this therapeutic window becomes a razor's edge, which means half a tablet extra and you're dyskinetic and flailing around, half a tablet less and you're stuck, right? And that is unpredictable, so it's terrible. You don't know what the speed limit is on the road, and you take the foot off the accelerator, car stalls, you accelerate too much and you're in the ditch. So this is terrible to manage. And what the idea of DBS is, and it does it in appropriately selected candidates, it expands that therapeutic window without having to use levodopa in many cases, right? So that means that you're getting a steady, smooth day, reduction in off time, improvement in on time and quality. But what it doesn't do is it does not improve the quality of the on to better than what levodopa does. What does that mean? That means if levodopa doesn't get you out of your wheelchair, neither will DBS, right? DBS only makes you as good as your best on levodopa. Why? Well, we can talk about that till tomorrow, but not useful today, right? And that's important as part of our screening. So age, we talked about, somebody that does not have atrophy and dementia and all those things, and response to levodopa. Remember, I started talking about this right at the start. You must respond to levodopa, and the response must meet what you want to have done. And earliest cases of mine in 1999, patient had a great response to levodopa, upper body, could write, can talk better, but really what they wanted to do was get up out of the wheelchair and walk. Well, levodopa didn't do that. So this is not a candidate for DBS, this person, because their goal, what we call goal attainment, was not achievable by giving them their levodopa. Many other reasons might have been there for that, but it wasn't something that levodopa would treat, hence we could not do DBS. The therapeutic window for gait could not be improved. Right, so age less than 70, but we're beginning to consider slightly older patients now, 72, 74, depend on how they pass their tests. We do what's called an off-on assessment. We bring the person in after a 12 to 16 hour off, no meds for 16 hours, levodopa that is, dopamine agonists even longer. We bring you in the off state, do a rating scale, give you usually about 150% of your oral levodopa, so like 4 tablets in front of us, watch what happens. And if that on is spectacular and you go from a UPDRS score, higher the worse, let's say 50 to 15, fabulous, right? This is the kind of person that will do really well with DBS. We can get you down to 15, it's nice and smooth all day long, or 24 hours really, because it's on all 24 hours. Right? And no contraindication to brain surgery, and no cognitive impairment. We cannot do DBS in patients that have cognitive impairment at all, which means a strict neuropsychological assessment is done, because one of the side effects that is permanent, even if you turn off the device in some patients if they have a DBS and we didn't screen, is cognitive decline, which we obviously do not want, right? And so last slide, one or two little slides left. This is actually the new stereotactic targeting system that we use, ClearPoint. This is now another company, Medtronic, that provides us with the electrophysiological equipment, but we have three companies, two that we use commonly, Boston Scientific and Medtronic. And there are two types of devices that we put in. Most of the time now, we're putting in rechargeable systems, which give you 15 years. In the past, all the patients that we've been using, a 5-year battery, which you have to change, sometimes in 3.5 years, depends on how much current we're putting in, and it's an outpatient surgery. The procedure is done in 2 parts, all in 1 day. The first part is targeting and localization, which after we put the stereotactic frame under local anesthetic, burr holes are drilled into the skull, like you can see there on the right, and it's a smart frame, a trajectory frame. And now we don't use this as a modern frame, we use an older frame. Electrodes are placed under guidance of this computer system that tells us we're in the right spot. Once we're there, we take out the targeting electrodes and put in the real electrodes. You're still awake through all of that. Once the 2 electrodes are in the brain, caps are put on so that the electrodes are held in place. Then we give the patient the general anesthetic, and the electrodes are tunneled underneath the skin all the way down to the chest. Cut is made, we put a pacemaker, connect it up, stitch it up, and you wake up, right? And we wait about a month, 6 weeks for everything to heal. Make sure you don't pick at it, and of course you lose hair because we shave your head. And so after all that's healed, then we start the programming. Takes 2-3 sessions of programming, 6 to 8 weeks before we get the current and the pulse width and which channels and all of that kind of stuff. It's become a very complicated system now, and won't go into details of that. And we, not us, but the companies are looking at using automated software to program. But it's been very, very difficult because the variation in patient population is so large that the computer doesn't really recognize whether you actually have postural tremor, or you're shuffling, or right foot is dragging. That information is not input into the software, so it doesn't. So you still have to sit there and tell it, then it's kind of might as well do it yourself. And the more the number of electrodes that are put in, or channels, the more programming becomes complicated. And we spend hours doing this programming in some of these patients, some of our patients with this, right? And so here are those devices. This is the Boston one. The rechargeable ones, as I said, last 15 years. And it's a very nice system in terms of the fact that you have a charging station that has a little, like a scarf that charges on the station. Every morning that's ready and charge, you just put the scarf around your neck, and it transcutaneously, so through your skin, will charge the pacemaker. You don't have to plug it into yourself into the wall. I mean, that'd be really awkward. But and in the past, literally, you'd have to sit there with the charger. But now you can just, it's literally a scarf. So you put that on like this, like a bandana, and you walk around. It's nicer than this actually, but and it'll charge in 20 minutes, half an hour, and you're done. You take that away, put it down. It's really. Well, we tell people to get into the habit of doing every day, but it would probably last 7 days. But if we say 7 days, you're going to go 10. And so we tell you every day, so at least you'll do it every other day, right? And so, we are all human finally, right? And so we say, no, do it every 15 minutes, then you get it done. No. And the reason for that, is that in the old batteries, which were rechargeable, the Medtronic ones, it gave you 3 opportunities to lose the charge. And at the third time you discharged it, it wouldn't recharge. And so the person would come in crisis, right? And so terrible because the device just shuts off and you cannot recharge it. Even we can't start it, it has to be replaced. And so now these don't have that kind of, the old batteries used to have memory. I don't know if you, but I certainly, these rechargeable batteries, if you didn't charge them at the start full, right? Only half charged, and that's all it retained, but that was the tech then. Now it doesn't matter. These lithium batteries, the Boston ones, you can half charge, quarter charge, but keep it charged. I mean, the last thing you want. The negative of the rechargeable system is travel, right? So if you, go away to Florida and your charging station is in London, not a good thing because yes, it charges transcutaneously, but doesn't charge over the telephone, right? And so it doesn't work like that. You have to have the unit. Where the non-rechargeable one, the battery was in your chest, and so it didn't matter. You went with it. So it was. And it drained over 5 years, so you had that much time. And even with, it's kind of like your gas tank. When the red light comes on, you still have time. So you usually get a month for the, In Parkinson patients, in general, we have not put in the rechargeable ones because after about 10 years, the efficacy because of progression of disease drops anyway. So why put a 15-year rechargeable system in someone that is not going to need it? But I think that's not fair. So you have to have an operation every 5 years then. And assuming you do really well, then 3 operations it's not a good thing. So we are generally putting in that. And again, everything is improved the motor and non-motor symptoms. Again, remember, responsive to levodopa, right? Responsive. And so will the wearing off disc. In many patients, we reduce levodopa to just twice a day, right? Something like this. Not a promise, but often happens like this. In fact, we have to reduce levodopa because if you put current and give levodopa by mouth, patients will develop severe dyskinesia. So you have to. Location and targeting is complicated, which we won't go into, and obviously the side effects are known, bleeding, stroke. About 2 to 3% of patients can have a seizure on the table, and if you pick at it again, so there's no requirement to give antibiotics right at the start, right? So we don't treat unless you get an infection. If the infection seeds, unfortunately, you got to take the whole system out, and then we can't put another one for 6 to 8 months because everything has to heal, oral antibiotics. So the real requirement is take care of it for the first 6 to 8 weeks. Don't get it infected. Because if it gets infected, then it's a mess afterward. Nobody's happy, patient, surgeon, and we have to manage now this person. Because patients who end up in getting device-aided therapies, we have not run out of, but really said that's what we want to do, right? And that's the reason you went to the restaurant, and that's the menu item that's not there. Then okay, what do you do then? I mean, as a clinician managing such a patient, we don't have 10 other options, otherwise we wouldn't have put you there to begin with, right? And so that's why the difficulty is there. And then there can be things such as speech and gait problems. Cognitive effects are irreversible, right? And we've had patients who've had, interestingly, and this is reported in the literature extensively, personality changes. And this is a hard one, right? Because all of a sudden, this is a person that has fluctuations and dyskinesia, is disabled, has caregiver, and all of a sudden the day is fantastic because you can do lots of things that you couldn't do before. Sometimes it goes overboard, and I've had patients whose husband has just disappeared, and then 3 days later, so where is it gone? Because playing on the golf course for 3 days. No, it's not, but it's actually a manic state that can happen as well. So it's beyond control, and so you can have such psychiatric side effects that can occur. And device-related problems, obviously battery failure, and there are people here who have had DBS who know this. There are now much more complicated programs and systems that are coming on the market, constant current stimulations, closed loop systems, like this kind of a thing, which I was just talking about, and this is my last slide, where you have a programming session going on. This is what we do, where there's a sensor system, and we have them in my lab. We've developed them in my lab, the sensor systems that can do these things, still exceedingly complicated to feed the sensor system data on gait and walking and biomechanics of all our body movements into the processing unit and then into the programmer to stimulate, to put the programming into the brain to make that optimized. It's very, very difficult to do, but lots of attempts to do this for obviously access issues. For example, we have patients from Thunder Bay who we've done DBS on, and well, they can't come every 3 weeks for programming, can they? But then how do we program these people? Either we don't offer them the treatment at all, or we tell them to move to London, which may not be possible. And so that's why there's a lot of effort being put into doing some sort of autonomous programming. Some things you can, I mean, tremor is easy, and the system can recognize the oscillation and increase the current and get it better. But gait is very difficult to quantify, right? We have gait carpets that are $100,000 in the lab. You can't have that in community places and hospitals. So, that's a very rapid overview of what we now call device-aided therapies, in removing the word advanced from your vocabulary to understand that these are patients that are still very responsive to medications. We have the need to treat them, not failed treatment, right? And so think about it this way. And lots of this, that's why I was saying to Dr. Young that, Parkinson's disease, despite the fact that I've done movement disorders 30 years now, is still an enigma, right? And we do rounds at the end of every clinic, and all my fellows that I've trained, many over the years, we must discuss a case of Parkinson's disease every round. We have lots of interesting, exotic, weirdo, genetic cases and whatnot, but Parkinson's still is a pain in the rear end to manage, I can tell you, and because of the variation and complexity, keeps us on our toes. But the fun part of it, in a way, I suppose, is all of these amazing interventions that we've had over the years since levodopa came 60 years ago to where we are today, Right? So thank you very much for listening to that. Appreciate it.
Thank you so much, Dr. Jog. So now we have time for question and answer period. So if you could just raise your hand if you have a question, Mark will come over.
David?
Okay, so we're going to start over here.
Hi, Dr. Jug. I've had DBS in now for 10 years, and I've been starting to fall lately. Now, is that anything that DBS can fix? Or?
It's a good question. I mean, one of the things that we want to make sure that it's not a side effect of programming, and so we always try to change programs, maybe bipolar, triple polar stimulation techniques that we have. But at 10 years, it's more than likely that it's a Parkinson progression symptom and postural instability in Parkinson disease. And that if it's not responsive to levodopa, remember I said it has to be responsive, then it's not usually treatable by DBS either. Right, so the first thing we do is make sure it's not a side effect.
Yes. I have DBS and a dead battery.
Oh, that's not a good thing. So you don't have DBS then?
Not anymore.
Okay, good.
So my question was, if I can remember what it was,
Should you replace the battery? Oh.
yeah, I had.
Oh, you have a replacement
I
in
have
January.
a
So
replacement,
okay.
and I still have trouble talking, which is not my question. Okay.
I
Yeah,
have a
yeah.
question over here.
Dr. Jog, now, with the DBS, you mentioned that every 5 years, with the battery, you have to change it or whatever.
Yes.
Now, going to the pump, does the tubing in the stomach need to be changed at
All
some
the
point?
time. That's the problem with that device, and it's not 5 years. You ain't gonna get 5 from it. In fact, there's a lot of debate with my colleagues in AbbVie are here, the medical people from AbbVie and us that actually do the treatment, whether on a yearly basis we should just go and replace the tube, because then you get a new tube. But that doesn't guarantee that the day after you replace it gets plugged, because it doesn't actually, it's not wear and tear of the tube that seems to be the reason why that tube gets plugged. It just sometimes can get plugged. And so it's still better to replace it when it's plugged rather than proactively replacing. I think, I'm not sure, Chris, we've decided on what that is, what they manage. Some people are doing this, but it's not a reliably validated approach of algorithm of treatment. But yeah, the tube gets plugged. That is, the pump doesn't die. The pump is an external thing, right? It's almost always related to the tube. Yeah. It has to be changed.
We understood when we were evaluated at Toronto Western Hospital that there was a smaller pump coming soon.
Smaller pump coming soon. Well, we've been hearing that for a long time. And, the smaller pump is coming soon. That's all I can say. I mean, I think the problem with it is that, fairness to the company, everything that is done to a device like this, or let alone medication, has to then be, there should be regulatory approval. The button color changes. I mean, I'm probably being a little old, but you have to get it through the FDA, through the and that's onerous. I mean, it's ridiculously onerous. A new electrode which has a size of the contact 0.5 microns more has to be resubmitted for evaluation. So I think, is the technology there for the smaller pump? 100%. But then what gets put through, how much it takes time to get through, et cetera, is what delays the...
So nowhere is it available?
I don't think that a smaller duodopa pump is available anywhere. No, not in Europe. No. The new technology that is coming, which is subcutaneous levodopa, I'm not going to talk in detail about it, which is subcutaneous, and it's a little needle underneath, which every 3 days you have to replace and put in another spot. It's a different pump. The original pump for the studies was smaller, but the pump that is going to be marketed is somewhat bigger. I don't think it's as big as the duodopa pump, The tech is different, but and there's another pump therapy coming soon,
I have
where
a
you
question.
don't need the GI. Yeah.
Over here.
You're welcome.
Rob Barnett, thank you for a very informative and upbeat presentation. Can I ask for DBS, how many patients are lucky enough to receive this?
Super question. So less than 8 to maybe between 8 to 10% of our total PD population, right? And that's a very biased statement, right? Because I get patients that are referred potentially for device-aided therapy. So if you were to look at Parkinson patients in the community, I may not even see those patients that are not, right? And so it depends on my denominator. So when you say 10% of my clinic population, doesn't mean that's 10% of Parkinson patients, because that may be that those people don't even come to us, right? And
So related question, how much MR time is required to do DBS? And is it done right here at LHSC for you? Or,
yeah. So
okay.
how much MRI time?
Yeah, to do one.
Very, very short, because the only the initial frame placement and targeting on the map is done under MR. After that, we don't have intraoperative MR requirement. We use electrophysiology. Now, it's a good question, just as a quick segue, there are centers in the US and in Europe that are doing entirely MR-guided placement. I'm not a big fan of that because, again, you're only using imaging. You're not actually using any electrophysiology. It's much faster, and it's done under general anesthetics. The person is put under MRs in the OR, you put the electrodes in, do an MR, adjust the location MR, and then you just place the electrodes, 3 hours, you're done. And the person is asleep. So it's called a sleep DBS. We don't do that. We do awake DBS, where we localize the target. We feel that's better so far. Yeah. Good?
Perfect. Thank you so much for your questions, everybody. Yep.